everyone, this is Dr. Pruett. Today is an exciting day because it's our first time in the new AFR media studio, working out how to use this new vector for teaching. And the perfect way to do this, I thought, was with the new guideline updates for 2021. As you know, we update these annually with some big changes that have been passed through the Medical Control Board, and wanted to give you a preview of these. It's important as we move forward that you realize this is just the cliff notes. So you're still responsible for knowing everything in the guidelines and practicing your patient care in accordance with those to the best of your abilities, but I wanted to give you some highlights of the things that are new and a little bit different this year. Really where the focus was in our content as we reviewed the guidelines and looked at where we could update things this year was with the procedure pages. As you know, we transitioned to the app a couple of years ago, and that seems to have worked pretty well. We this year focused on updating the guidelines for procedural changes as well as for updated pictures, and just to make them a little more user-friendly and ideally helpful. So as always, if you have any feedback on these, please pass those up through either the training division or through your 7-8. Some of the biggest procedure pages that got changed this year were the vasopressor cheat sheet. I'd like to see us using vasopressors a little bit more for our patients who are experiencing any type of shock. We tried to make that easier in terms of dosing and drawing that up. So there's a nice cheat sheet for your reference. I'll show you a little bit later. The other thing that is a little bit new is for needle decompression. We've been doing a really good job recognizing the indications for this, but there's some new and emerging literature that suggests that the anterior axillary line is actually the most effective space to go to perform a needle decompression in a patient who has tension pneumothorax physiology. So you'll see that spelled out here. Just a quick overview. If you look at the base of the armpit hair on the patient's chest here going anterior to that, just under the base of the armpit, it'll usually get your best access to the chest cavity to reinflate that lung. We also did a lot of work on the airway pages with the devices that we have, and also just procedures for controlling and managing an airway effectively, and then some capnography reference pages as well. So here's a quick look at what the vasopressor sheet is going to look like. You can see at the top here, there's a nice pictorial of how to make an epinephrine mini bolus. You basically take your 10 mils of epi, you waste 9, so you have 1 mil of epi, and then you can insert 9 mils of saline into a bag that'll give you a nice 0.1 milligram remaining in the bag that you can titrate as needed. If you have a pump and you're able to make a drip, which is even a better option and a little more reliable, you can take either 1 milligram of epinephrine or 1 milligram of norepinephrine, put that in a 250 cc underfill with normal saline and drip that in, and you can titrate your drips to a MAP of 65. This will help in your patients with shock. So hopefully a nice condensed, easy to use table that will encourage us to use our vasopressors a little bit more in our shocky patients. Looking at the brand new guidelines for 2021, these are some pretty exciting things that I, again, hope are really helpful for you as you're out there practicing medicine in the field. One is going to be a sedation agitated patient scoring system to help you figure out how much Versed to use or when to pull the trigger on ketamine. Again, ketamine is still only an AAS skill, but it's going to help give you a little bit more of a decision-making matrix for how much to use to sedate your patients if it comes to needing chemical sedation. We have Benadryl for dystonic reaction, some new updated COVID treatments. As the literature is emerging, it's time to integrate those into our practice in the field for our COVID patients. Ventilator usage, now that everyone in our system, including Albuquerque Ambulance, Bernalillo County, and us have a ventilator. That's just standardized across the system for use. And then a little bit about bannering for MCIs. So to start with, this is the big one for this year. This is the Sedation Scoring Index, Behavioral Severity Index, and you can look at the scale of 1 to 7 here, anywhere from confused to attacking people. And that has a description here that you can kind of put your patient into a category. And based on which category they fall in, as you're grading their behavior, you can determine how much either Versed or ketamine you need to use. So hopefully this is a tool that you have in your toolbox to help you manage your medication and your scene safety. Again, the most important thing is keeping yourself safe and taking care of your patient in the most appropriate manner. For dystonic reaction, I know this is taught in paramedic school, but it hadn't been in our guidelines in a while. This is within the scope of practice, so it's nothing new that needs to be trained on, but you probably want to review it. This is a painful muscle spasm that can happen when anyone starts taking antipsychotics or certain antiemetics. And usually sometimes it's in the neck. You'll see them kind of twist their neck off to the side. It's important to note there's no other neurological symptoms with this. So no numbness, no tingling, no slurred speech, anything. It's simply a painful muscle spasm in the setting of antipsychotic medication use. And the treatment for that is Benadryl. And so now that's in our scope of practice. I know I've gotten a couple of MSEP phone calls in the past for this. Now you won't need to call for it. You can just give it based on the guideline if you have the correct patient. And as COVID is becoming more prevalent in our community, for the patients who are known COVID positive or highly suspicious for being COVID positive, those with positive family household members or a test pending with all the right symptoms, who are hypoxic, that's a big caveat for this guideline. They need to have an oxygen saturation less than 90. If that's the case and they have COVID or are highly suspicious for COVID, then we can give them dexamethasone. This is in the field. You can either give it IM, IO, IV, PO. There's lots of options for dex. And if they're profoundly hypoxic, we've just spelled out some more oxygen strategies for you. It's always important to remember to be careful with the aerosolizing procedures. But if they're profoundly hypoxic, you're having a hard time improving their oxygen saturation with just a nasal cannula or just a non-rebreather, you can put a nasal cannula on at 15 liters with a non-rebreather over it, also cranked up all the way, and that'll supply a lot of oxygen to get you to the hospital. You need 2 bottles for this, but it does seem to be pretty effective for our hypoxic COVID patients. Ventilators are new in our system. This is very exciting as our step forward as a system. AAS has them now, Bernalillo County, we have one as well. It's important to note that these are only to be used with apneic patients who have no inherent respiratory drive. So typically these will be our cardiac arrest patients, because right now for AFR, the only unit that has this available to them is the 7-8 vehicle. So it should be showing up on scene with the 7-8. These are the settings. There's a whole training out there on ventilator use and why this is important, but here's a quick slide looking at how to set the pressure relief valve, how to turn it on, set your tidal volume based on your size of LMA, frequency of breaths, the positive pressure that it provides, and then the percentage of oxygen that it provides as well. So pretty easy settings. There's lots of training out there for it. Get your hands on it if you can. Get to know it. The reason that we started to incorporate this into our system is we know that if we can provide consistent rate and depth and volumes of ventilations, patients do better. So just like with our Lucas device, Lucas doesn't get tired when he's doing chest compressions. Ventilator is pretty much the same thing. It's not run by adrenaline. It's not multitask. The ventilator will be able to deliver consistent rates and volumes to our patients who are the most sick. And there's lots of evidence to support that this is a good step forward for our system and for our patients. Lastly, in terms of new things for bannering and MCI, if you get to a scene of a mass casualty incident, make sure you do your scene size up. You're working on your triage, and you identify who is a black patient, red, yellow, and green. Essentially now, you only banner if you have 5 or more red or yellow patients. Your greens don't matter for bannering. Those are walking wounded, and they'll go to any hospital they can. The reason we're bannering is to give the hospitals a heads up, and UNM will automatically take the first 4 red or yellow patients. Once we get to that 5th patient, we're going to start having to disperse among area hospitals, and that's the purpose for the banner, is to give the other hospitals a heads up that they might be getting a trauma patient that's a little higher acuity than they're used to seeing. So make sure you review these criteria. There have been minor updates to the formulary. Some of our changes with the pressors, particularly the epinephrine that we did for the presser cheat sheet, had some residual effects on basically every guideline that has epinephrine in it. So make sure you're looking at your epidoses. What we tried our best to do is standardize the epidoses. So you just need to memorize 1 for adults, 1 for peds, and they're the same across the board, no matter the situation. Again, just to make it easier on you as a provider. But make sure you're reviewing that epinephrine usage. The presser cheat sheet we already reviewed. And then a lot of the pediatric doses we tried to standardize with the adults as much as we could. Again, just to make everything a little more simple, a little more standardized, with the idea that less math and less critical thinking is easier for anybody in a difficult situation with a patient. Please, 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 as we're talking about medications, a point of emphasis for a quality assurance committee is just to make sure you're doing your medication cross-checks. When you're administering a medication, make sure it's the right medication, the right patient, the right dosage. It's not expired, and the right route. Make sure you're doing all your 5 rights. We have had some missteps over the last year. That happens. It's okay. If it does, just report it. But do your best to be conscientious up front. Certa dose, I know you all have seen it. There's a training out there on this as well. Just wanted to re-mention that thank God we haven't had many pediatric arrests in the last several months, but if you do, this is a device that ideally will make your med math a little bit easier. You have the pre-marked syringes with the tape here. You can basically just color code the child and get your automatic dose for any of your PALS drugs that you would need. So make sure you get your hands on this, play with it, figure it out before you have to, so that when the time comes, if you have to use it, you're familiar with it and know how to use it. We have some new reference pages there too, just for you to look at if you need to. They're not going to change anything you do, but one of them is for capnography, all the different situations that capnography can be helpful in troubleshooting what's going on with your patient. A lot to read there. And then a little bit of information about vasopressors and how they work and how they act and which one is better in which situation. So just there for your academic interest and reference if you need it. The areas that we're going to emphasize this coming year as a quality assurance committee are going to be number 1, ACLS rhythms and treatment. There's going to be a lot of case studies coming out just based on patients that we've seen in the field and how we could treat them and recognize what's going on with them. Another emphasis from the training perspective is going to be airway management, so a lot of hands-on skills, cricothyrotomies, intubation, CPAP, bag valve mask, all of those things that are very important for patient care. And then as a system, as a whole, for our county and for our city, we're going to be looking at stroke metrics. So making sure that we're doing a really good job identifying stroke patients, moving quickly and getting them to the facility where they need to go. So that's our job as a system kind of oversight of the city and county EMS. In terms of advanced cardiac life support, if you have any interesting 12 leads or any interesting cardiac patients, please submit those either to the 7-8 or to the training cadre. All the information will be de-identified. We won't call you out as a crew. We might even change some of the patient demographics. The whole idea is just to take interesting cases that you're seeing and use it to spread the word and train other people so that everyone can learn from this experience and not just one crew. And then for airway management, we mentioned lots of hands-on skills, hopefully intubation, CPAP, cricothyrotomy, maintaining these as an essential part of patient care. And then in terms of strokes, looking at our LVO patients. So performing Cincinnati when it's indicated, moving on to LAMS, identifying LAMS greater than 4 needs to go for thrombectomy, making sure we get time of onset of stroke-like symptoms, last known normal, and doing our best to get a contact number for either a family member or next of kin who can provide information about the patient. That's really, really helpful for the hospitals. Just a quick reminder that there are certain things, all of our time-sensitive emergencies do need a notification to the hospital ahead of time, and the earlier you can do that on scene, the better it is for the hospital. So the minute you recognize a STEMI, go ahead and let that hospital know that you're coming. That gives them it buys that patient a couple more minutes to get to the cath lab, get that cath lab ready for them, and it can save heart muscle over time. So STEMIs, septic shock, ECMO transports, and then LVOs, all of these are very time sensitive. Now, ECMO is on hold pretty much right now, except for the hypothermic patients, just given the COVID situation. So my advice would be still train yourself to recognize ECMO candidates, and the best thing you could do is just call an MSEP and ask what they think, if you should transport and treat this like an ECMO candidate, or if you should just stay on scene and work it like a normal cardiac arrest. Just given the situation in the hospitals and the ICU right now. I anticipate this will be changing over the next year or so, but it's really hard to predict the future. But for sure, you still need to do early activation for STEMI, for sepsis, and for strokes. And then just a quick note about documentation. Make sure you're getting repeat vital signs if those are indicated and you're with the patient for more than five or so minutes. Use your drop downs for procedure. This really helps for QA purposes. And also another thing that really helps is we're looking at system data and trying to pull trends and numbers is doing the best you can to give a correct provider impression. So really take a look at that provider impression list and try to be as close to accurate as you can. If you have any feedback about that provider impression list, please either give it to me or I know the RMS office is happy to talk about it as well. We want to make this user-friendly for you, but also something that's useful to pull systemic data on the other end. And then make sure you're uploading your 12 leads. And most importantly, I know this has been a tough year for everybody. You guys have been doing a fantastic job with your patient care. I review close to 200 charts every month, and I can't tell you how proud I am of the job that you're doing taking care of the citizens of Albuquerque. And just want to say keep up the good work. I'm really proud of you, and I'm excited for next year.